So this presentation will be about the strategies that we have to treat patients with resistant depression, focusing on all the possible strategies, particularly on switching versus augmentation or combination that are the most difficult part of our job. I will show you some of researches that have been done in my group I'm a clinician, as you are clinicians, and so all the research that you will see just comes from the need that we have. I have the same needs that you have. You have a depressed patient that is not responding, and you don't know what to do. And actually, as we will see, the guidelines are not that clear about what to do. They give a lot of suggestions, but the specifics are not there. So I will guide you through all the possibilities that we have to treat resistant depression, focusing on specific strategies. As you have heard before, the problem of depression is that you have to treat the depression. Because if you don't treat depression, this is known since many years, there are damages that are also physical damages, anatomical damages in the brain. There are damages in the hippocampus that is shrinking, but not only. These are old studies, but new studies confirm as well that the brain of depressed patients that are not adequately treated goes into some kind of problems. That could be atrophy of specific areas or lack of connections between frontal and limbic areas. There are a lot of issues. This is why it's important to treat depression. And the longest, this is also quite an old study, but new studies confirm, the longer time you wait years to treat depression, chronic depression, is doing a big damage to the brain. So just these two slides to be clear about the need of treating depression. Depression itself, if not treated, usually goes worsening. One episode, another episode, more episodes, longer, more severe, more difficult to treat. This is why it's important to treat depressed patients. I was impressed by a slide from the presentation before that when you have a sample of patients with depression, you realize that some of them are kept on the same medication for many months without any change. It happened also to me to see patients that had the depression since 6 months with 50 milligrams of sertraline, low doses, one single drug without any change, anything. This is wrong. This is wrong because if you don't treat those patients, you go into real problems. Not to mention the cognitive adaptation. Patients with depression, they adapt to be depressed. So after 1 year, 2 years, it's very much more difficult to treat them. Not to mention suicide, of course. So let's think about the big variability. These are real cases from our studies. How they go. Patients have a very different outcome. Talking about weeks, some patients improve and stay well, some patients worsen and then improve, some patients don't improve at all. So it is very variable, the situation. We did some of our studies, also on American databases, to try to understand which are the predictors of outcome. But there are not too many, actually. Like as we have seen for suicide, there are not too many predictors of suicide. There are not too many, there are some. And also in terms of outcome, there are some predictors that we should keep in mind that are not solving completely the problem, but that can help us a little bit about the treatment. First are the socio-demographical predictors. We know that patients with higher education, more income, not living alone, and good employment usually have a good odds ratio of going well, but not so much, 2 point something. Also, the clinical predictors are sometimes useful. For example, longer duration or severity of the episode, higher suicidal risk, a higher rate of family history or side effects during treatment. These are all good predictors, but again in the range of 1-2%. The previous presentation mentioned also genetics. Genetics could be useful, but in the future. This presentation will not focus about genetics, but just a small information that in the future genetics can help us probably a little bit more. So we should keep in mind some patients that have a high risk for treatment-resistant depression versus low risk based on clinical and demographic predictors. But then it happens. It happens that we have in front of us a patient that is not responding to the first-line treatment. And which are usually the specific predictors? Baseline severity, early onset, comorbidity with anxiety or abuses, and of course traumas and no social support. All these factors are important because we can focus on them. We can make specific treatments on each one of them. But this is not part of this presentation. Just let's keep in mind that we should not use antidepressants alone. It's a comprehensive treatment, psychotherapy, cognitive behavioral therapy, when needed interpersonal therapy, family therapy. Let's keep this in mind, but it's not the focus of the point. The focus on the point is how to manage the pharmacological treatment. In this paper, a recent paper that I wrote, I just focused on the point of how it's difficult to choose the right treatment for the right patient. We have more than 40 antidepressants, and we have a lot of other psychotropic drugs, more than 100. So the combination, how to use them, is not easy. I know that you are working with patients every day, many visits, many consultations, and you don't have much time to decide what to prescribe. Patient is not responding to sertraline. What should I do? I can use bupropion, I can use paroxetine, I can use escitalopram. So this is difficult, and this is what I wanted to say in this paper. The first step to be sure that the patient is indeed a treatment-resistant patient is to follow these specific indications that are coming from guidelines. First, to be sure that the patient is treated in an adequate way. That is, sufficient dose for sufficient times. I've seen many cases that are treated for 50 milligrams of sertraline for 1 week, and then the doctors say, oh, it is resistant. No, after 1 week, it's not possible to say that it is resistant, and it's not possible with 50 milligrams of sertraline. You need to increase the dose. Second, we have seen another terrible information from the previous presentation that is confirmed by other studies in literature, non-adherence. Usually up to 50%, half of the patients, as we have seen, don't take the medication that we prescribe. Then we can prescribe whatever we want. If the patient is not taking it, it's not useful. So this is another point we should work on. How, with a good relationship with the patient, if possible, to check the plasma level in the blood of the patient. When possible, we have to face this, but let's keep it in mind. And also side effects. We have to consider that all the drugs that we have give side effects. Some patients are not happy with side effects. If there is weight gain, sexual dysfunction, insomnia or hypersomnia, this should be investigated during the consultation. And of course, comorbidity, and of course, we have to be sure about the diagnosis. If a patient has hypothyroid function, we can give antidepressant how much we want, but depression will remain because it's due to thyroid function, not from depression. So medical analysis or check for sleep apnea, nutritional deficiencies. Many women, for example, they have low vitamin D, low iron. So always check for blood samples. Yes.
For example, in the case of sertraline, how high will you go?
Yes.
How high?
Exactly. It's just the next part of the presentation.
200.
Good question. Good question. Don't worry, we'll go there. So what to do when you are sure that your patient is treatment-resistant depression? So you ruled out all the medical comorbidities, you ruled out all the nutritional deficiencies and things. You are sure that your patient is treatment-resistant depression. Well, there are steps. Optimize those that we will discuss first. Switch, combine, and augment. Let's discuss one by one this option. Okay, the first one, before going to this, is optimizing dose. Optimizing dose, as we discussed, is to go to the maximum of the label. So to answer to your question, you want to start with sertraline because you thought that sertraline is good. Wonderful. Start with 50. After 1 week, go to 100. After 1 week, go to 150. And if the drug is tolerated, go to 200. You stop increasing only if you see side effects. In case of sertraline, usually you see diarrhea and nausea. So if you see some diarrhea and nausea, then stop. What I teach to my residents is antidepressants should be used at the maximum tolerated dose. Because the more you give, the more you block the serotonin transporter, or it goes to the other serotonin receptors in the brain, it's more effective. And we will see also later in other studies that we have done. So the higher dose as possible. This is good rule for every antidepressant that we use. And this is the most common mistake that clinicians do, that don't go to the highest possible dose. I told you the example of a patient that had sertraline 50 milligrams for 6 months. This is a big mistake, of course. Okay, so we are talking about resistance. Talking about resistance, the first concept that I want to make very clear is that among all many antidepressants that we have, there is not one that is more effective than the other. It happened to me, it happens to you, that the patient asks you, please doctor, give me the best antidepressants, give me the most effective antidepressant. The very clear answer from the big meta-analysis is that there is not a most effective antidepressant. The overall efficacy is very similar, very similar. The differences that you see amitriptyline and mirtazapine is just because they are more sedative, so they decrease more the anxiety scale. But overall, they are very similar. So the first myth about treatment, there is not a more effective antidepressant. But they are very different one from another. So there is not an overall best antidepressant, but there is the best antidepressant for every patient, because everyone is different. So if someone has a lot of agitation and insomnia, mirtazapine and amitriptyline would be good. But on the other hand, if someone needs more, for example, anti-anxiety effect, escitalopram is good, paroxetine is good. If someone needs more activation, venlafaxine, because it has a noradrenergic effect. So it depends on the patient.
Sorry.
Yes?
Sorry for interrupting.
Sure.
Are there any head-to-head comparison study among the antidepressants?
Yes, this is a network meta-analysis that combines head-to-head studies all together. This is a very huge study that has been done by my colleagues from Germany, Stefan Laupt and Geddes from UK, and Andrea Cipriani, that is from Verona. They put together, I didn't put the abstract, but something like 20,000 patients, head-to-head comparison. And these are the results. So this is quite clear. I was talking to you about the dose before. Well, we did a series of studies a few years ago, not much, 5 years ago, about the plasma level of the drug. The plasma level is very important because in the guideline, it is not clear if the plasma level is good to be high or low. Therefore, we did these studies, this and the next one. The first one was an escitalopram. Why escitalopram? Because escitalopram is one of the most used drugs. You know, there are no interactions. The CYP enzymes is pure on a serotonin system. So this is a drug that, of course, is used a lot. But the question is, how much escitalopram you should prescribe? In Italy, we have drops and tablets. Sometimes I see patients with 5 milligrams, 8 milligrams of escitalopram. This is not enough. And this is the demonstration. Because the improvement, this is the Hamilton depression scale, improvement in terms of plasma level of the drug, it has a very clear curvilinear association. It means that at low doses, this plasma level corresponds to less than 10 milligrams of escitalopram in general, depending on the body weight of the patient. Low doses are not that effective. You need medium, high doses to be effective. So, the rule I told you 5 minutes ago, when you prescribe an antidepressant, and this is the case for escitalopram, but also for the others, go up 10 milligrams, 15 milligrams, of course, depending on the age. If the patient is 80 years old, no. But if the patient is older, 40 years, 50 years, go up to 20 milligrams without any problem, because otherwise it is not working well. And you have to be careful. That there are few cases, but it is more clear in the mega-analysis that we did later. If you give too much, then you can have some side effects, and then it's not working well as well. So, rules are, increase the dose and ask for side effects. Did you have any nausea? Did you have any constipation or diarrhea? Did you have any sweating? Do you have any movement of leg in the night? Headache? If you have side effects, then stop. Otherwise, increase. And this happens at 1 month and 3 months. And this is exactly the same for duloxetine. Duloxetine, a little bit less clear, but more or less the same at 3 months. You have a perfect dose of duloxetine. So also duloxetine, go to 60, 90 milligrams, wherever is needed, increase. Otherwise, it's not working, but not too much, also in this case. And this is more clear, that too much high doses are not good. Okay, so we discussed very well the first step, optimizing the dose. What we should do next? You do your best. You exclude other reasons for treatment-resistant depression. You increase the dose, still is not working. Then what? These are the most recent Maudsley guidelines from UK, London. They are very good. They are very good. I suggest them to use to students. They are very good, precious. So I suggest you to use them. But something is lacking also in the Maudsley guidelines. They suggest start the antidepressant. If it's poorly tolerated, change it. If it is effective, go on. If it is not effective, increase the dose and then switch. Okay, good suggestion. But what is in between? You could have a situation where it's a little bit effective, but not too much. 20% of response, 30% of response. This is not in the guideline. So, the guidelines are good, but something is still missing. What to do in partial response? If some symptoms improve, others don't. So this is what I want to focus in the next slides. These are the guidelines, but we need something more. Okay, let's go to the center of the presentation. Switching means change antidepressant. Maybe you can do in 1 day if it is very similar serotoninergic. You can do in 1 week if it is a different class, more slowly. This is what most commonly people do. This is what is suggested also by the Maudsley. This is what it was the standard usually in the past. But we, my group and the European groups, we are not convinced, and now the guidelines are changing, we are not convinced that switching is always good. Why? See the results. A few years ago we did this study with the European group, and we've seen a very interesting thing, that if you give antidepressants to a treatment-resistant patient, not responding, and then we had 2 options. Use a same class drug or a different class drug. So it could be serotoninergic, or serotoninergic, noradrenergic. Well, the results were very clear. If you switch class, patients respond less. And this is counterintuitive, because usually we used to think, oh well, serotonin is not working, let's give a noradrenaline antidepressant. It's not so simple. Why is not so simple? Because in another study, we saw something that it is even more clear. If you don't switch, not to the same class, don't switch, just continue the same drug, or you switch. If you switch, the situation is much worse. Why? Well, the next slide makes it very clear. This is the outcome after 4 weeks of treatment, patient not responding, green continuation of the same drug, red switch. You see what's happening? You have to wait 1 week. Because if you change mechanism of action, you start again from the beginning. So you give sertraline again for 4 weeks. Patient is not responding. Then you continue sertraline, or you give, for example, nortriptyline, something that is completely different, noradrenergic. Nortriptyline, given here, needs 1 week to work all the post-translational mechanism, noradrenaline transporter, early genes, hippocampus, the mechanism of antidepressant is slow, it takes 1, 2, 3, 4 weeks. So you start again from zero. This is why you lose time. And this time is very dangerous also for the presentation before in terms of risk of suicide. Because at this point the patient can think, oh well, I am not responding. The doctor changed my drug, but still I am not responding, so I'm lost. It's better that I suicide. So this is very dangerous. If you continue, the mechanism go on. So which are the take-home message of this? Be careful about switching, because switching can delay your improvement. Then you have improvement, of course, in the following weeks, but you lose 1 week. And these are quite old studies, 10 years ago, that demonstrate what I have seen. But also very recent study, I show you this important on JAMA journal, so very, very high. And then they demonstrate the same, that if you switch compared to augmentation with two very different substances, aripiprazole and bupropion. Aripiprazole, you know, is wonderful for augmentation because it is partially dopamine blocker, 30%, so you have an increase of dopamine, it gives more energy, at the same time it decreases anxiety. And bupropion is also interesting because it's a pure dopamine transporter inhibitor, so you combine dopamine with serotonin antidepressant effect. Well, both of them are better than switch. Switch, that is the blue line, is always the worst. So this is not only our studies, also very important studies, and this is another extremely high journal, New England Journal of Medicine, very high, that did the same in geriatric depression. And again, the results are that if you change from previous treatment to bupropion, you have some benefit. If you combine bupropion with the previous treatment, you have more benefit. If you combine aripiprazole with the previous treatment, you have even better effect. So, summarizing the first point, switching, the most common strategy. Be careful, be careful. Be careful because you lose time. So when to use switching? When the situation is really negative. For example, there is no improvement at all, less than 20%. Or if there is poor tolerability, if the patient tells you, listen doctor, with this drug it's really a nightmare. I have nausea every day, I'm vomiting in the morning, okay, then you have to switch, of course. And then sometimes, if you have some improvement, it's better to go a little bit longer. But the question is, when you switch, which is the other compound? And this is an information that can come from what you see. For example, the patient with, again, sertraline is telling you, oh doctor, not only am I not improved, but I have more anxiety. Why? Because sertraline is also dopaminergic, then okay, then let's go to a very anti-anxiety drug like paroxetine or escitalopram that are more sedative on anxiety. So you take the information of what happened in these 4 weeks, so you decide which is the next drug, for example. Okay, then the second strategy, combining. be careful that combining is different than augmentation. What is combining? Combining is to combine two antidepressants. Augmentation is one antidepressant and something else. So, two antidepressants is a good strategy or not? Depends. The meta-analysis gives some various results with an overall effect that the combination is better than monotherapy. Well, yes, of course, combination is better than monotherapy, I agree. But not all studies are in the same direction. Why? Because it depends from the patient. I use a lot combination. For example, again, sertraline. Patient says, okay, you give me sertraline 100, 150 milligrams. My depression is better, but still I'm not sleeping well. Then, combination with low dose of mirtazapine that improves sleeping. This is combination. Or a patient tells you, well, I'm better with escitalopram, but still I don't have the energy that I had before. Then combination with bupropion, that is more dopamine stimulating. These are examples of possible combinations. So combination is good, and as the article says, you should combine what is needed from the patient that you see. So combination is a good strategy if you see some benefit, and then you want more benefit. So you don't switch, you combine. Of course, be careful about interaction. So I use this website. There are many websites that you can use. There are also apps on the phone. Check interaction. So when you, for example, escitalopram is very well tolerated, but with aspirin you must be careful because of the blood, the risk of bleeding, but this is for all SSRIs. So when you prescribe a combination of drug, and this particularly for elderly people that take 5, 10, sometimes 11 drugs, go to the website, put all the names, don't be shy, it's important, and then you check if there are real and dangerous interactions or not. So to summarize combination. Combination is really a powerful strategy. Be careful about interaction. Be careful also about pharmacodynamic interaction like serotonin syndrome. If you give too much push to serotonin in the brain, you can have some cases, not very common, I saw 2 or 3 in my life, but you can have serotonin syndrome, so be careful. And you must be very careful in terms of choosing other antidepressants. So focus on the mechanism of action. The last strategy, augmentation. So we discovered that switch can be used when there is no benefit at all because you pay the price of waiting the effect of the new drug. Combination is good, but you must be very careful. Augmentation is another interesting strategy, but augmentation with what? Well, there are various possibilities. The Maudsley, as a first choice in terms of augmentation, put aripiprazole. Aripiprazole, of course, is a very easy strategy. First, it's quick. You don't have to wait. Aripiprazole effect on the postsynaptic partial dopamine effect is immediate. So you have suddenly, in 1 day, 2 days, you have some effects. Wonderful. So there is good evidence, well tolerated, supported by meta-analysis. Of course, it's an antipsychotic. It's a good antipsychotic, but it's always an antipsychotic. So be careful in terms of akathisia or possible neurologic side effects. And it can be too much stimulating. Some patients with aripiprazole have decreased sleep. In this case, what to do? Well, you could switch to brexpiprazole, that is a little bit more sedative. These are examples. Lithium is a good potentiation, augmentation, mainly for patients maybe with mixed depression, patients that have a family history of bipolar disorder, so some bipolarity there, lithium is wonderful. And then we have the combination of olanzapine and fluoxetine. These are the 3 first choices from the Maudsley. I agree with this. This is very I agree with to match with this strategy. Olanzapine and fluoxetine is known since quite a long time. I know that you have it in your country. We don't have it in Italy. We have to give a separate one. But my suggestion is to stay quite low with olanzapine. It depends on the case, but usually 2.5, 3, maximum 5 is sufficient in combination with fluoxetine. Of course, consider the risk of weight gain depending on how much olanzapine you give. Even if fluoxetine can balance this, but you must be careful about that. So these are the most common option of augmentation, but they're not the only one. Another one is quetiapine. Quetiapine is wonderful because you can give very low doses of quetiapine, 25 milligrams per time, that improves sleep, or 50 milligrams and 25 in the morning for anxiety. Or you can combine with bupropion. I told you the example before. You can give some bupropion that gives more dopamine energy to the SSRI. Or you can combine with venlafaxine, mirtazapine, and so on. Or you can combine also with other atypical antipsychotics, not only aripiprazole. For example, there is evidence also for not only olanzapine and aripiprazole, but also for risperidone and many others. This very recent meta-analysis, this was last year, makes a comparison of all the second generation antipsychotics. Well, the overall effect is very similar for aripiprazole, olanzapine, quetiapine, brexpiprazole, cariprazine, ziprasidone, and risperidone. Very similar compared to placebo. Again, like for the antidepressants, there is not one that is better than the other. They are just different. So, aripiprazole is more stimulating, brexpiprazole is more sedative. Olanzapine is more sedative, but also very mildly antidepressant. Quetiapine is good depending on the dose for sleeping. Cariprazine is very delicate. Ziprasidone we don't use much in Italy. Risperidone is good because it's blocking completely the dopamine receptor D2. Therefore, it's good in those patients with a lot of rumination, with psychotic-like symptoms, but it's not good for patients that maybe are very sedated with anhedonia. I will never give risperidone to a patient with anhedonia, of course. So you have to choose not on the basis of the overall effect, but on the basis of the specific patient profile. Then there are some second choices. If the first choices fail, so you don't switch, you don't augment, you don't switch, you don't combine, you augment, it doesn't work, then there are some second choices. Of course, the most common is ketamine and esketamine. Nasal esketamine. Probably intravenous is more effective than nasal, but the results are not clear so far. We will see a slide later. It is, of course, a good option, but it's quite expensive, by the way. Lamotrigine, that is another strategy that is good, and then of course there is ECT, electroconvulsive therapy, thyroid hormones, and a very long list of other options that I will not go into detail. But consider that if you go into meds, most of the guidelines, they can give you some suggestions. Sometimes I use S-adenosylmethionine, that is a very well tolerated strategy. There are many good suggestions here. We don't have time to go through all of them. So in summary, the last strategy of augmentation is good if there is a small improvement. So first line treatment is giving some small improvement. Let's add something that can give even more improvement. One that I did not mention from the slide before, for example, is modafinil. Modafinil is good because it's a drug that is used by neurologists that gives more wake up. It's used for narcolepsy. And sometimes I combine modafinil with the SSRI. If patient is sleepy during the day, modafinil is good. Just for an example, or pramipexole also. There are many combinations that you have some kind of improvement with your first line treatment, and then you have to add something to improve even more. And you have to individualize. Of course, there are disadvantages of giving more treatment together. Okay, let's go to the final part of the presentation. Which are the other and new strategies that we can use? Well, there are a lot. There are a lot other than usual ECT. Transcranial magnetic stimulation and the direct current stimulation are improving a lot. When we first used transcranial magnetic stimulation 20 years ago, was not very effective. Now they improved the protocols, and there are some new strategies that I will show later that are much better than it was before. Then you can use light therapy, vagus nerve stimulation. There are some developments also in the deep brain stimulation where you put some electrode through the skull, but this is quite an intervention. I told you about the new strategies about the TMS. There are a lot of new strategies, intermittent and continuous theta burst stimulation, where they change the sequence of the stimulation. 3 pause, 3 or continuous stimulation in 2 minutes, 1,800 stimulations. And indeed, if you work on this, and there are a lot of papers since 2-3 years on that, you can have much better efficacy of the transcranial magnetic stimulation. Particularly in this other very interesting and very recent study, they combine active transcranial magnetic stimulation with active direct current stimulation. Both of them very well tolerated. And the combination of the two, well, is more effective than one or another. So these physical treatments are improving a lot, and it's something that we will use for sure. Then there are all the new treatments. These are some, but there are many others. Ketamine, esketamine, but also psilocybin. We published a paper I put somewhere here, esketamine and brexanolone. Brexanolone is another new treatment that is a neurosteroid for postpartum depression, but probably also for other kind of depression, that is working quite well. Not a huge effect size, but well tolerated and could be a good idea. And it's not the only one. There are other ones under development. There are many new drugs. So, US FDA approved both of them, brexanolone and esketamine. And what is interesting about ketamine and esketamine is that there are also new formulations. This is again the Mosley guidelines. There is a subcutaneous formulation of esketamine. There is intramuscular, but there is also oral. Oral is much better than the spray because it's more convenient, the plasma level and so on. There is also sublingual form of esketamine. So also esketamine administration is improving to be more feasible, more easy for us. So going to the end of the presentation, I want to remind you about the difficulty and the variety of our patient. This is quite an old study that I published a few years ago, where I did a detailed analysis of 2 of my patients. I remember that one was a patient with very severe depression that indeed responded very well. And another one was a woman with a mild depression that became resistant. I tried a lot of strategies, but it didn't work. Then I was wondering myself, why? What's different? And then I did a very detailed analysis of these just two cases. Detailed means including everything like personality, defense mechanisms in terms of psychological functioning, a lot of tests, IQ, intellectual quotient. I did all the tests that I could. And then I understood looking at the data that these 2 persons were very different. She had a very dependent personality, she lost her husband, and so she didn't have the resources to go out from the depression. And so drug treatment could not do much because it was a combination of personality, environment, while the other case had a lot of resources, family, good work, higher intelligence, and therefore it could recover from severe depression. Why I focus on this? Because I would like to remind you that every case is different. So we should not use sertraline, escitalopram, paroxetine, duloxetine for everybody. No, every patient has its own treatment, its own SSRI or combination or augmentation, depending on everything, comorbidity, physical tolerability, and so on. So, in conclusion, which are the myths and truths that I would like you to remember from this presentation? Well, the first that I strongly point, a lot of people, some people suggest depression should not be treated because it's a natural process. No. It's like to say pneumonia should not be treated because it's a natural problem, but you die with pneumonia if you don't take antibiotics. So it's not something that we should do. We have to treat depression. If you don't treat depression, the natural story of depression is going worse and worse. So we have to treat depression. Other people, and there was a big discussion about 15 years ago, antidepressants don't work. They do nothing. Not real. Not real because there is full of evidence that antidepressants work and we have to use them. But we have to choose carefully for every patient. Another myth is that switching is better than combining. This is the point of the presentation. Is better switching, change the drug, or combine? No, there is no better. It depends on the situation. If there is a small improvement, combining is better. If there is no improvement at all and tolerability is not good, then switching is better. One drug is better than another. No, they are just different. Polytherapy and monotherapy depends. I learned when I was very young, 24, 25 years, my director was insisting a lot about using the less therapy as possible. I agree. Of course, I was trained like that. So I prefer to use less treatment as possible. But sometimes it is needed to use a combination of treatment. Sometimes, not always, sometimes. And some people say physical treatments are better than drugs. No, they could be good, but depends. Some physical treatments could be more effective in patients and less in others. So they could be combined together or combined with treatment. So this is my last slides, and thank you for your attention. And if you have any questions, I will listen. Thank you.